Hi, everybody. Um, we're just going to talk about another ECG today. My apologies, I am recording it from home, and if there are some continuity errors, we do have, it may be the kids just asking for something. I may have to pause and then just start again. So I'll ask for your understanding before. So this is the one we were going to have on the 15th of March. Which is the Monday. Let me just get everything up. So it's an interesting one and one that is scary when you do have to face it. So let's begin. So the first thing that we do, and like I told you, it's a scary one. I know when most people see ECGs like this, they immediately start to panic because you immediately feel that you can't work this out. But we're going to get through it, and you're going to see by breaking things down into little chunks, you're actually going to start to understand what's going on over here. So we have a 74-year-old man with chest pain, palpitations, and remember we analyze axis, analyze rhythm, as we've done before, P waves, PR interval, QRSs, are they narrow or wide, QRSs after every P, regular groupings of PQRS. We analyze the rate, and then we analyze each zone after that. So let's go to the big one, and then we'll take it from there. So let me just hide this away. All right. So let's start by looking at the axis. So we've got lead 1 pointing upwards, and we've got lead AVF pointing down. So if you recall, if lead 1 is pointing up, it's either a normal axis or a left-sided axis. And AVF, if it were pointing upwards, then we would have a normal axis. But because it's pointing downwards, we know we have a left-sided axis, right? So the axis is actually the easy part of it. It just tells us something's happening on that left-hand side, okay. Let's go to the rate because I think we can start there. So if let's pick one here. So we've got one less than 2 blocks. So we're looking at about 160 to 170 beats per minute. So this is obviously a tachycardia. So I'm sure you guys have already guessed that this is going to be a rhythm disturbance. But let's try and have a look at what rhythm disturbance it could be and try and pick out what we can see in each one. So first, let's have a look at our rhythm strip here at the bottom. I think that's actually going to tell us quite a bit. So the first thing is, can we see P waves? And the answer is that it's quite difficult for you to actually make out. Is that a particular P wave? I mean, these look like T waves here. Is that a little P wave there? You know, it's difficult when you look through the whole thing because there are areas where they look like P waves, and then there are areas where you can't make out for sure that there is a P wave. So can we say we have normal P waves? No, we can't. We definitely can't say that. So it's difficult to talk about a PR interval where we do see a P wave. For example, where you see what looks like a little P wave over there. To confirm, we'd need to look right through the whole basically through that entire line and see if we can see P waves somewhere else. And it does become a bit difficult to see them. So we can't really talk about a PR interval with any sort of authority. We can't talk about a QRS following every P. But what can we talk about? We can talk about the QRSs themselves. So what do we notice about these QRS complexes? They're extremely wide, right? Even if you look at them here, they're quite wide. And as I taught you guys before, if you have a QRS complex that's wide, that means that the signal is coming from the ventricle. All right, so from the AV node or lower, that means that it's not really receiving any sort of input from the atrium per se, which kind of fits in with what we see here, where we can't really see the P waves. There may be some hiding in here, which we'll get to just now. But the most important thing is that we can't actually see any atrial input. We can only see ventricular input everywhere. Okay. And then if you look at the groupings are relatively regular. If you look at them, they do vary ever so slightly, but it's a minimal variation. So let's just think about it for a second. So we've got this ventricle that's in tachycardia. And why do we say it's a ventricle? Because we've got wide QRS complexes. So we learned that if we have narrow QRS complexes with no P waves and a tachycardia, we are looking at a supraventricular tachycardia because it's coming from above the ventricle. So if we were having a wide ventricular complex, it would imply that it's a I know I can't hear you, but I'm just pausing so that you can work it out in your own mind. A wide QRS complex with a tachycardia, in other words, a tachycardia of ventricular origin would be a ventricular tachycardia. So that's what we are seeing over here. So this is quite typical of a ventricular tachycardia that we see. Okay. So the other way that I always describe it to people is it looks like vampire's teeth, dragon's teeth, if you turn it upside down and things like that. But that doesn't mean that we've got the diagnosis. We just need to sit by and wait. We still need to look through what we can see in each zone just to check. Now, in saying that, there's a few caveats at the end, but we'll get to that, all right? We are looking now at a heart that's going extremely fast. We are looking for what we can see. What else can we notice in the rhythm is T waves. So we can see these occasional T waves where the body is trying to repolarize the ventricle before it what you call it discharges again. We can see them here. We can see a few T waves. Could argue that those are possible P waves over there, but it's unlikely because you've got these wide QRS complexes all the way over here. Although here they look a bit narrower if you look at them there, and then when you come there, that looks like what you call it, a hidden P wave maybe. So there's quite a bit that's going on in this ECG. And if you're faced with this immediately, now you may start wondering, all right, should I look for ischemia? Should I not look for ischemia? It actually becomes very difficult to look for ischemia in these types of patients simply because of the morphology of the QRS complex. So ischemia is very possible, and you can get ischemic changes. You can see changes in the ST segment, but in order to find changes in the ST segment, you have to be able to identify the ST segment. So the question is, what's going on? Is that a P wave? Is that a T wave? What is that little notch over there? So you understand where the difficulty comes about. Now, we're going to get to the answer just now, so we'll know how far we were, how close we were. And if we look at this, then we can see the septum, the anterior part, the as we get towards the lateral border. But mainly here we see where the ventricular tachycardia is mainly taking place. But let's go through each zone. So we look at zone 2, 3, and AVF. We see similar patterns to what we've seen before, these wide QRS complexes. And then, we come to V1 and V2, the septum. Again, these wide QRS complexes, typical of ventricular tachycardia. V3, V4, also typical of tachycardia, ventricular tachycardia. When we come to V5, V6, and if we look at these, we could argue that maybe there's some ST depression over there, maybe even here. But and then when we come to AVR, we see, is this an ST elevation? Is that a hidden T wave, P wave? It becomes so difficult at the end. And the truth is that in the emergency department, all these little niceties are not going to make much of a difference to your treatment because your treatment is going to be the same. So the important thing is that we know we have a ventricular tachycardia. Now, ventricular tachycardias can start for a lot of causes, all right? Ischemia is definitely one of them, but electrolyte abnormalities are more common. Um, Extraneous or what you call it, extraneous pacemaker cells. There's so many things that can trigger it off. Direct trauma can sometimes trigger off a VT. There's a lot of things that can cause it. So the thing is, if we have our diagnosis and if we know that it's ventricular tachycardia, the question is, what next? What do I do? How do I treat this patient? But first, let's just see if we were right. Then we'll answer the questions on the management. Okay. So, yep, we are right. It's a ventricular tachycardia, the rate of 170, all right? So you see here, they say the ECG could easily be mistaken for supraventricular tachycardia with right bundle branch block based on QRS morphology in lead 1 and the appearance of retrograde P waves following the QRS complexes. So that's a nice way of talking about something that we call SVT with aberrancy. Okay. Now, this is something we'll get to later in the year. I don't want you guys to stress about this right now. Okay. So the important thing is that ventricular tachycardia can simulate a right bundle branch block and a left bundle branch block pattern. So in other words, it can look like a right bundle branch block there, and it can look like a left bundle branch block on that side, which is why it becomes so difficult to say if they are bundle branch blocks and things like that, all right? And it can also be associated with retrograde P waves. So retrograde P waves, oh, sorry, wrong way. Retrograde P waves would be, for example, here, what we were arguing about. Are those P waves or are those not? What are those? So those are what you call retrograde P waves, what we're seeing over there, all right? Again, these are all nice things to know, but the important thing is to make the initial diagnosis, which is of a ventricular tachycardia, okay? The patient had repetitive episodes of dysrhythmia despite medical treatment. Ablative therapy was curative. Now, ablative therapy for us in our situation most of the time is not an immediate treatment. What do we do? I mean, we can't treat this patient with ablation. This patient need to go to electrophysiology, which is now only available at Albert Lutulia and I think at Gray's if you're in KZN. So they're not easy things to sort out. Ventricular tachycardias can actually be quite difficult. However, it depends on the underlying cause as well. Now, the thing is, I don't want you guys to stress right now about what we call aberrancy. This is a nice way of talking about something that we call aberrancy, which we'll get to later on. The truth is that from all of the ECGs that you see that look like ventricular tachycardia, 95% of them are ventricular tachycardia, and 5% are this thing, or what they're talking about here, right? Where you have an SVT with a bundle branch block, and that's why it creates that. So don't stress about that. The important thing is to remember what a ventricular tachycardia looks like. And if you can remember nothing else, just remember vampire's teeth, all right? Especially if you turn this upside down, it looks exactly like vampire's teeth. So try and remember that that's what a ventricular tachycardia looks like. Okay. So ablative therapy, why? Because you want to remove the pathways, the electrical pathways. So let's compare a supraventricular tachycardia to a ventricular tachycardia, because this is something people often find difficult, you know. We could even say we could compare it to a sinus tachycardia, and let's know and see what happens over there. So in an SVT, you don't have P waves, all right? In a ventricular tachycardia, you have P waves may be present, but are often not really associated with the QRS complex, like in this one, where they have retrograde QRS complexes. Okay. SVT is a narrow ventricular complex because remember, the stimulus is coming from above the ventricle. So because it's coming from above the ventricle is narrow. However, in ventricular tachycardia, you have wide ventricular complexes. The reason being the stimulus is coming from the extraneous cells, pacemaker cells, or from the what you call it, the ventricle itself, the AV node, and so on. So you get these wide ventricular complexes. SVT tends to range between 150 to 180, whereas with ventricular tachycardia, you can easily go above 200. It has happened quite often where you get extremely high rates of VTAC. Okay. Now compare this to a sinus tachycardia. So if you had a sinus tachycardia, we would have P waves that are present, narrow ventricular complexes, and rates that are generally below 150, generally. Now it depends, you know, sinus tachycardia is normally due to pyrexia, hypovolemia, hyperthyroidism, things like that, some chemical electrolyte abnormalities and so on. So they very rarely go above 150. So if we had to add sinus tachycardia, SVT, VT, and put them next to one another, we would say sinus tachycardia, P waves present, P waves absent, and here the P waves not associated with the QRS complexes. Sinus tachycardia and SVT would have narrow ventricular complexes. VT would have wide ventricular complexes. Sinus tachycardia would have a rate generally less than 150. SVT generally between 150 and 180, but it can be higher. And VT can easily go above 200. Okay, so that's the thing to remember. So the question is, how do I treat it? And we come back to our algorithm. Okay, so the one thing I can tell you is that with VT, the first thing is worry about stability. If your patient is stable, and remember the most important thing to look for is hypotension, because hypotension will lead to the rest of these. They are a consequence of the hypotension. A majority of your VTAC patients will be unstable. All right. It's very rare to find a stable VTAC. All right. However, if you do get a stable VTAC, by all means, you consider doing all of these things as we've spoken about before. You know, you could mix up adenosine, which we know is very difficult, or we could give amiodarone in our case, which we would, as we said, we put about 300 milligrams in 200 mils, and we give that over about 10 to 15 minutes. And, you know, the vagal maneuvers, it don't really help. I must be honest with VT, vagal maneuvers, I haven't seen them assist. That's for sure. However, the most common thing that you need to do is synchronized cardioversion, all right? And when we look at these VTACs especially, now remember, we've got SVT would be a QRS that's narrow and regular, and you cardiovert. A QRS that's narrow and irregular, so in other words, an atrial flutter or an AF of less than 48 hours, we would consider this. Now we're getting to this, where we talk about a QRS that's wide and regular. You cardiovert at 100 joules. So you start off at 100 and then build up from there. Remember, your patient has a pulse, they are perfusing, so you're not doing CPR. You're just trying to get that back to sinus rhythm. And for those who maybe haven't, go back to where we talked about SVT and have a look at the synchronized cardioversion video that's on this that you guys can see it. All right. And then QRSs that are wide and irregular, we'll get to later on. Okay. But don't worry about them now. Let's just say that you turn your machine onto sync mode. You put your energy at 100, and then you do the QRS. I mean, you do your synchronized cardioversion at 100 joules, and you'll see your patient will hopefully improve. If they don't, then you go up to about 130, you can go up to 150. Once you start going up to 170, 180, by that time you should have a blood gas back. You should be looking for electrolyte abnormalities as well. And in some cases, we have to do overdrive pacing for these patients. It's not something I'm going to get into now, because that should be something that's done under physician guidance in ICU. Um, but remember, so in a VTAC, generally they are unstable, so there's no need to follow this part. However, if you do get a stable one, amiodarone works much easier. Adenosine unlikely to help. The reason being, you've got adenosine that's shutting off the vagal nerve. The vagal nerve doesn't have much to do with the ventricle, so it's very rare that it would help. Amiodarone, on the other hand, because of its mode of action, it's interesting pharmacology to read about. But essentially, to break it down, it separates your T wave from your QRS complex. All right, it does that by doing certain channel blocks, and it allows your QRS complex and your T wave to actually become further apart. By doing that, it decreases the chances of your patient being in a ventricular tachycardia. We'll get to these more complex topics later on in the discussions. But for right now, amiodarone is probably the one that you need to look at. Okay. And then remember, you start to cardiovert at 100 joules. It is very scary. One of our doctors last year, I remember, I'm not sure if she listened to this, she is on the group. I had to do this, and in the middle of the night, she phoned me, and we did it over the phone. And I think she needed a bit of treatment for her own tachycardia after that, because it is scary when you've never done it before. But we cardioverted the patient, and the patient immediately responded, and we put the patient on amiodarone thereafter, and the patient settled down quite nicely. So the last slide that we're going to look at is just some interesting variants. Okay. So this is something that you see, which is called concordancy. Concordancy means, and it's in what we have with our patient, is that the QRS complexes all generally seem to be pointing in a positive direction. Maybe you could discount V6. And this is one of the things that's quite typical about ventricular tachycardia. It tends to be concordant. Okay. So in other words, the QRS complexes all tend to point in the same direction. So if they were pointing down, they would all be pointing down. If they were pointing up, then they would all be pointing up. For here, for example, we see negative concordancy. So they're all pointing down. All right. They are still, it's still a ventricular tachycardia, and we can see because of the wider QRS complexes, the absence of P waves, the tachycardia itself. All right. So that's one of those. Now, this one is just something that you can see. And these are just for interest's sake, just something. This is nice to know, but if you don't remember them, don't worry. All right. So a capture beat. All right. So this is where supraventricular impulse causes depolarization of the ventricle, resulting in a narrow QRS complex. In other words, you've got this VT, and every so once in a while, the atrium just pops in a little hello, how are you? And your patient goes into a normal rhythm and then immediately goes back into VT as well. All right. Then this is called a fusion beat, where you suddenly see this narrower but almost similar to your wide QRS complexes, be a complex B. And this can happen sometimes when you've got a fusion of supraventricular and ventricular impulses. So this doesn't mean you have an SVT mixed with a VT. It just means that an impulse from the supraventricular area is sort of fusing with the ventricle. But it's just for interest's sake. These are things that you see, but the main thing is to treat the ventricular tachycardia. None of these change your management, right? And this is AV dissociation. So remember we talked about AV dissociation not being equal to third degree heart block. And this is one of the cases where you see it. So these are little P waves that are hidden inside over there. And you can actually see that you've got these little P waves, but they have nothing to do with the actual underlying pathology. It's not going to change what we're going to do. This is more typical of the vampire's teeth, as well as these. So I hope you guys enjoyed that a little bit. I know it's not the longest one we've ever had because we've covered tachycardias a little bit now. What I am going to do, I just wanted to see if I had, um, no, I hadn't done any sort of polls for this. I thought maybe we could, but it's not really a problem. So the most common questions people ask is that, what do I do? And this is the answer that we've given. You need to follow this algorithm here. Okay, the one that we've talked about here. This is where we need to do. My advice is that if you get a VT and they are hypotensive, you immediately go to this. Because what's going to happen for this, you must remember your heart is so dependent on diastole for its own coronary artery supply. What's happening is you have this ventricle that's just pumping, pumping, pumping away. And before it really has a chance to go into diastole, it's pumping again, pumping again. So besides putting your patient into a metabolic acidosis very quickly because of high output, all right, which can lead to heart failure and things like that, what's going to happen as well is you are going to start getting ischemia because before your aorta can relax and allow blood to fall down into the coronary arteries, it's being forced to pump out again. So you get this decrease of blood that's going through. So you start getting these ischemic changes, and eventually that leads to cardiac arrest. So that's why you've got to be careful and you've got to try and treat them quickly. Now, it's the same with SVT. However, because SVT, the rates are a bit lower, there's a bit more of a diastolic um, amount of blood that goes in compared to a VTAC. So you do have to be a little bit more careful. If your patient is unstable, I wouldn't stress about vagal maneuvers and things like that. I would only worry about, if your patient was stable, I would worry about amiodarone. And if your patient is unstable, immediately cardiovert them and then put them on an amiodarone infusion, as we've talked about before. So I hope you guys enjoyed it. I know it wasn't the most time consuming one, but I still hope that you guys learn something from it. It's not something you'll see every day. You may see it once or twice a year, but in your emergency department, you need to know how to treat it. If you're at a district level, remember you've got no time to transfer this patient. They'll be dead by the time you send them to a regional hospital. So you need to know how to cardiovert your patient. So I would suggest everybody go look at the machine, look at how the machine goes into sync mode, look at how their paddles work, which hopefully I will teach you guys once we do our general emergency department topics and we go through the head, and which is what I've been stressing on. We're going to do resuscitation and we'll talk a lot about the defibrillator as well. But I hope you guys enjoyed it and I hope you learned a little bit from it. And yeah, hopefully we will get back to our normal ultrasound lectures from Wednesday and our emergency department topics after that. But keep well. And like I say, I hope you enjoyed it. I'm going to end it up now. And yeah, everybody enjoy their day. Thanks. Bye.